Hello everybody. So I'm glad to be here and to talk about the force technology, and my task today is to show you an edited case I thought was quite interesting because it gives you insight in the way this technology is able to reduce radiation, but also to help you during the navigation phase in the aorta. So this is my disclosure. So for those physicians that perform on a quite regular basis this complex aortic procedure, I think that radiation is still an issue. This is an example of a patient who came in our unit with a past history of an aortic roof replacement, and as you can see here, he has a quite big thoracoabdominal aneurysm. So typically in these patients, what we do is we treat them in two-step procedure. The first step consisting in deploying in a branched aortic arch stent graft. The second step consisting in deploying either a BVAR or a TVAR, and in this specific example it was a TVAR. So you can see that when patients are selected properly, the anatomical results of the branch exclusion is quite satisfactory, but of course this kind of procedure is associated with a significant amount of radiation. And when it comes to treat the thoracoabdominal segment, as you can see here, it's even more radiation, specifically in obese patient and in patient having some metal implants in the body, as you can see here. And at the end, the level of radiation, again, is quite significant for both the patient and the medical staff. So we do have, how you heard before, tools to reduce radiation in our current practice. You've got, as Stefan said, the ability to use a fusion mask. With the Philips platform, you could be able to use a 2D, 3D fusion. That's what we do when we have simple cases such as EVAR, but when it comes to treat more complex cases such as FEVARs or BVARs, especially when you have to do a coil embolization before, we tend to prefer 3D fusion, as you can see here. And this is the kind of final display you can choose according to your preferences. Of course, you can also use the lowest radiation dose protocol. Here is some examples. You don't need to use a frame rate of 7.1 images per second. In our practice, we reduce that to 3.7 images per second, which is perfectly fine to treat all those complex patients. Also, rather than using the magnification button when the image is not large enough, it's also probably better to use properly the collimation and again the digital zoom. And as you can see here, there's an example of a graft limb deployment. Instead of shooting an angiogram to have a proper mask, we simply use fluoroscopy, store the images, so without doing any angiogram, and then use the images as a marker, put the marker tool, and then can deploy the stent graft without having too many informations on the screen. So I think the force technology is a step forward, in 3D, in navigation. And as you can see, this physician is able to manipulate both the wire and the catheter without doing any X-ray, and this in 3D and in color. So basically how it works, device can be tracked using light traveling through hair-thin integrated optical fibers, and when you send the laser light in the fiber, the way it is reflected in the fiber gives you the ability to reconstruct all these devices in 3D and in real time. So this is an overview of the setup of the system. You'll see that there's a LumiGuide engine connected to a docking base that is dedicated to be connected in sterile condition with this force-enabled wire. That is the only device to be tracked at the moment. It's a bit like a Terumo wire. It's a 0035 soft hydrophilic wire with a working length of 120 centimeters. And since the catheter at the moment are not tracked, Philips developed a very convenient tool, the 3D hub, which is able to recognize all the catheter you use in your daily practice. And before commencing the navigation phase, you will need a shape registration phase, which doesn't take more than 5 minutes usually. First, you will need to register the guide wire by shooting 2 fluoroscopy in 2 different angles. Then comes the adjustment of the guide wire tip, which usually is not necessary. And finally, you will need to register the catheter, which again doesn't take more than 30 seconds. So it's a very quick process. Of course, you can use navigation for very basic steps of the aortic procedure, such as aortic navigation, aortic stent graft navigation, or the cannulation of a contralateral gate. You can also use this technology to adjust the position of a fusion mass. In that specific example, using the LumiGuide technology, we're able to cannulate the renal artery, as you can see here, and readjust the position of the mass without using any X-ray. But of course, it's more interesting for more complex phases of the procedure, such as target vessel cannulation. And what is really interesting with this technology is the ability to see multiple views and in real time. Look at the example of the celiac artery cannulation. The operator uses the profile view to cannulate the ostium of the celiac artery, and then you can switch to another view to see in which branch exactly your wire is going in. And here it was the hepatic artery. We sometimes use it for embolization before EVARs or FEVARs. As you can see here, we've got an example of an IMA embolization and a left gastric embolization. And what's interesting in those examples is that using 3D fusion and the LumiGuide technology, we were able, without any X-ray and without any contrast injection, to start the procedure before the coils were delivered in the patient. And this is the edited case. It was a patient with a past history of an aortic root replacement, and he came to our unit with a quite big thoracic dissection with a chronic aneurysm. And the plan for, when you're looking at the images of the descending aorta, you can see that diameters were not too large, and as usual, we had these re-entry tears at the level of the iliac arteries. So the plan for this patient was to deploy a custom-made branch, aortic arch, Cook device, and then to cannulate the false lumen to deploy a candy plug and obtain a proper exclusion of the dissecting aneurysm. I'm sorry. And before the operation, we determined the force-enabled wire task, which were 1, cannulation of the true lumen and the aorta, and then cannulation of all the supra-aortic trunks using the LumiGuide technology, and finally go back to the false lumen to deploy properly the occluding device of the false lumen. So here is the true lumen cannulation. We were able, of course, to do with the LumiGuide technology, and you can see how easy it is to make some progression using only the wire and the catheter without any radiation. And next, interesting, look at how it is helpful when it comes to cannulate the supra-aortic trunks. If you take the example of the innominate artery branch cannulation here, it's really convenient to have these multiple views, since you are able to see the position of the wire and catheter in relation to this diamond-shaped valley that leads to the branch, and we were able to do the whole process without any X-ray, using only the LumiGuide technology. And the same was true for the left common carotid artery cannulation from a femoral axis, as you can see here, and we were able to go inside the branch, and you can see how easy it was to make some progression using the wire and the catheter. And finally, we could do that also for the left subclavian artery, as you can see here, with the cannulation of both the branch and the target vessel. Before deploying the stent graft, the distal component of the stent graft, we had to adjust the fusion mask before deployment of this, and we decided to cannulate the celiac artery using only the LumiGuide technology. And at the end, we went back to the false lumen until the aortic isthmus, and then deploy the occluding device. And this is the final result, which was quite satisfactory, with no clinical events after the procedure. Thank you very much for your attention.
Thank you.